Great, so we're just going to give folks a moment to log on, because when you have several hundred people logging on, it takes a couple minutes. So good afternoon, everybody. We'll get started in just a few moments. Welcome. We have a great session for you this afternoon. Nice of you to join us. Hopefully you are joining us from someplace sunny and beautiful. I'm here outside of Washington, D.C. It's a very frigid, chilly day. Let us know where you are logging in from. If you're online, please go ahead and go into the chat box and tell us where you're logging in from around the country and around the world. We'd love to know where our participants are joining from. So go ahead in the chat and tell us where you're at. Be great to know. Great. Welcome, Pittsburgh. Welcome, Los Angeles. Frisco, Texas. I'm sure it's warm down there. Alexandria, welcome. Great to see you. Wisconsin. Niceville, Florida. That sounds like a very nice place. Wisconsin, Knoxville. All right. So we've got the Southern contingency with us here today. A bit of the Southwest, and looking for some folks from the Northwest, if we've got anybody. Welcome. Great to see everybody. Connecticut. Great. Welcome. Sandy Springs. All right. Let us know if you've got snow or sun or what's happening as well. Oh, good. So we do have Montana. Great. Welcome. Holly, Patricia, Danielle, Annette, why don't you tell us where you guys are logging in from today?
I'm logging in from Houston, Texas, and it's beautiful today.
Oh, great. So wonderful. All right. How about you, Patricia?
I'm logging in from near Titusville, New Jersey, in Princeton Pike, and also on the native lands of Lenape people.
All right. Well, let's see our tri-state contingency if you're here. Danielle, how about you?
Good old Kansas City, and it's sunny and kind of warm.
Okay. Kind of warm for Kansas in February. All right. Annette, how about you?
Jen, I'm in New Jersey. It's actually a very warm day for February in New Jersey, so can't complain.
Great. Welcome. Well, we've got a wonderful group with us here today to talk about health equity. So we'll get started in just a minute. It's just now 1 o'clock, so we'll give folks another few minutes. Great to see everybody here today. I want to see some New Jersey, New York, Connecticut folks to represent Annette here and Patricia. So join us if you're out there. All right. So I'm Jen Kovich-Bordnick. I'm the CEO of the EHI, which is Executives for Health Innovation, our new name, which we launched a couple of months ago. We're all still getting a little bit used to it, but we are still EHI, so welcome. It's wonderful to have you here today outside of Washington, D.C., a chilly day here, but a great day for a webinar to talk about health equities. So welcome, and so delighted you could join us here today. If you are tweeting, we'd love for you to tweet with us at eHealthDC. You can see our Twitter handle right there, and we'd love to get chat going. And this is a really important discussion, so feel free to join us on Twitter or our LinkedIn page. Why don't we go through a couple of introductory slides, and then we'll kick off the discussion. There we go. So for those of you who are not familiar with EHI, we're a catalyst for healthcare transformation. We convene leaders from across the spectrum of healthcare and try to figure out where are there opportunities to collaborate around innovation and health. And we really feel like it's important to bring all different diverse perspectives together. We like to bring our payers, our providers, pharma, life sciences, consumer groups to talk about all these really important issues about how to lower cost, increase quality, and really make care accessible for all populations. And that's why today's topic is so important to us. Next slide. We focus primarily on 4 different areas: modernizing public health, health equity, virtual care, and privacy and security. So we do a lot of education, advocacy, and thought leadership in these 4 areas. And we have a large number of resources available to you and programs if this is something that you're interested in. Next slide. This is a sampling of some of our leadership members. We have a great group of executives that gather quarterly to talk about these 4 issues. And if you do not see the logo or your organization listed up there, we would love for you to join us. So feel free to reach out to myself or Amy at EHIDC. And we would love to talk to you about how we can get you engaged in our activities and our programs. Next slide. So today's topic, community health justice, working to ensure health equity in care delivery. And as I said, we've got a really incredible group with us here today. I'm going to introduce them. I think we go to the next slide. You can see everyone's prestigious title here. We've got Patricia Doykos, who's the Executive Director of Health Equity at BMS. We have Danielle Jones, who's the Director of Diversity and Health Equity at the American Academy of Family Physicians, sporting the gear today, Health Equity t-shirts. I wish we had them for sale, but we don't. We've got Annette Powers, who's the VP of Access Marketing at BMS. And we have Holly Spinks, who is a nurse and the Chief Nursing Officer and Head Business Partnerships at Jasper Health. One of our favorite organizations working in cancer care. So great, wonderful to welcome the 4 of you today. And we're just going to get into a great conversation here about health equity. And just to get us started here, it'd be great to just kind of go around and hear from each of you. Why is it so important to consider equity in care delivery right now? And why don't we just start with you, Holly, because you're first on my screen in the corner.
No problem. I can definitely do that. So I think it's important to consider equity in care delivery, especially in cancer, because it's a disease that affects all, but it doesn't affect everyone equally, which is why it is really vital that all individuals impacted by cancer has an opportunity to achieve their best overall health outcome, no matter their race, ethnicity, gender, age, sexual orientation, social economic status, or zip code. And really, showing improvements in cancer disparities is where we're really going to see how we can measure progress towards health equity. And just understanding that equity is only truly achieved when someone has the opportunity to be healthy as possible, and no one is disadvantaged from achieving these health outcomes because of socially determined circumstances, which influence about 80% of our health outcomes.
Yeah. Patricia, why don't you add on to that? It's great.
Thank you, Jen, and thank you so much to EHI for creating the space for this discussion and inviting us at BMS to be part of it with these incredible leaders. Really a privilege to be alongside everyone. Well, I think it's important because all patients deserve high quality care, access to care and access to high quality care. And we know, as Holly was saying, that they're not all receiving that there are gaps between the kinds of quality of care along the continuum from screening to diagnosis to treatment, and then all the supportive care. Some of it's not even within a healthcare system, but community support organizations helping patients to manage their disease or to navigate through a complex disease like cancer, immunological disease, cardiovascular disease, and so on. So for the specialty care space, like cancers and like these other disease states, it's almost a graduated level of attention that we need to pay, because patients have to push so much further into the healthcare system to get to a specialist from a federally qualified health center or from a safety net setting. So really important there. One of the ways that I think that is important to think about is to stand in the shoes of the medically underserved patient now. And what is their experience becoming aware that something might be wrong, they're not feeling well, to getting linked to care, getting then to the specialty care and to the treatment and all the kinds of supports that they need. And that seeing the patient holistically is really the graduated idea of care. It's not just what happens inside the walls of a clinic or a hospital, and we're seeing digital health is changing that anyway, but also these supports around the patient in their community, in their home, to their caregivers and support system as well, so that they can really be in a 360 way and as a person supported as they go through a disease or an illness and come out as healthy as possible on the other side, or manage it optimally on an ongoing basis.
Good point. Danielle.
Yeah, I think why these conversations continue to be important is because we can actually quantify the cost in terms of both human lives and economic dollars of what health inequities are costing us as a country. And that number is only increasing, and it is in the billions of dollars. And so by not addressing these issues, I think we continue to do ourselves a disservice as a country concerning what we're losing by not addressing some of both the social determinants of health that we know are going to improve health outcomes.
And finally, Annette.
Thanks, Jen. You know, this is such a great topic. And for me, I was probably first exposed to this when I was a clinical pharmacist in the hospital in Newark, New Jersey. And I would see such disparities of the patient journey. Once patients were in the hospital, they got treated fairly, but the journey they took to get in the hospital, and many patients, you know, they utilize an ER as their doctor. They don't have the care. They don't have access to the same care. And, you know, we've seen with COVID, it's just been exposed and highlighted even more within the last 2 years. You know, as I see my journey now in the pharmaceutical industry, I really feel, and this is really shown with this diverse panel, that it's everyone's responsibility that works in the healthcare field to ensure that all patients get access to appropriate healthcare and medicines. And it's such a complicated process. There's so much more than getting diagnosed and taking a medicine. It's about everything that surrounds a patient in and outside just the health of that patient. So it's a fantastic topic.
We've talked a little bit about the problem. So how do we know when we've actually achieved health equity? What's that going to look like? I mean, you talked to Annette a little bit about, you know, how this goes back to when you were practicing. What do you think this looks like when it's actually been achieved and there's health equity, if that is even possible?
Well, Danielle touched on it a little with just some of the economics on that. You know, now with data, and I have a health economics background as well, and you can look at data. So Jen, to your question, you know, getting data, looking at social determinants, race, all of that, to look at access, treatment, outcomes, whether that's going into the hospital less, getting their treatment, staying on and access and that persistency of being on treatment, and looking at outcomes, whether, you know, morbidity or mortality. It's something that we should be looking at, and we should be looking at more. And I know, you know, speaking for Bristol Myers Squibb, it's a big push for us. It's studies that we look at. And, you know, in my department, that is our main goal. I mean, making sure patients get access to medicines, however that may be. And I think that's something that, you know, all of us can do better.
Holly, what about for patients who are dealing with cancer? What's health equity look like for them?
It really is, you know, when we can, you know, provide and we can provide cancer care to everyone, right? Outside of those kinds of barriers that a lot of them are faced with, and, you know, the disparities such as, you know, the lack of trust in the healthcare system, systemic racism, lower levels of prevention and screening and early detection, and the challenges around access to high quality cancer care and cost of care. If we can show progress towards removing those cancer disparities, we can really show, you know, equity within this population.
Okay. And Danielle, let me just touch on you, you know, as a representative of AFP and the family physicians, you know, certainly getting patients in to see practitioners is important, but kind of in a more general way, how will you measure success in this area?
You know, we can have all sorts of quantitative measures, both in cost and outcomes and access. But I think at the end of the day, and there's the great quote that says, is people won't remember what you say, it's how you made them feel. When people no longer feel that the quality of their health or the care that they receive is based on how much money they make, the color of their skin, their gender identity, that's how we'll know we've actually achieved health equity. And that's why relationships with the family physician is so important.
And we'd love for folks that are on today's webinar, if you can share with us in the chat box, we'd love to hear how you're measuring health equity please share with us if you've got metrics that you're looking at or your thoughts on this as well. So please, we want to make this as engaging as possible. So feel free to interact with the speakers as we're going through the discussion today. Patricia, let me head back over to you in terms of just BMS in general. Can you talk a little bit about what their overall approach is to health equity?
Yes, really happy to. And this is something that we've been thinking about for a very long time. I think it's certainly been intensified for us in light of COVID and how that really made plain the health and healthcare disparities that are out there and how they cut along racial, ethnic, geographic, different demographic lines, as well as this reckoning with structural racism in the country. But we've really been thinking about it, not only domestically, but internationally as well, including in low and middle income countries. So in the last couple of years, we've been working as a team to put together the answer to the question, what does it mean for a biopharmaceutical company to embed health equity in everything that it does? And there are two big areas for us. So one of them is changing ourselves. So we discover, develop, and deliver medicine. So how do we bring diversity, equity, and inclusion values to every step of that process? So in the R&D spaces, we're developing medicines, doing inclusive research, diversity in clinical trials, really engaging community voices in even structuring and giving guidance to how to deliver those trials, how to provide information to communities to engage them as well. When we think about commercialization, and Annette would be able to say even more, but even thinking about very straightforward things like multiple language materials for patients, really having a deep understanding of the populations that are disproportionately affected by the different disease states that we're looking to address in our company, and also what their experience is in accessing high quality care, accessing innovative medicines, having an opportunity to participate in a clinical trial as well. So that's really how change management is being used at BMS to evolve our business practice. And this only is going to help us to have better science, better understanding of the safety and efficacy of our medicines in real world before real world, or better insight into that. And then also an opportunity for us to fulfill our mission more by expanding the reach of our medicines to even more patients across the country and across the world. The second pillar is really beyond the pill, and we've talked about some of these things already. So what are those supports? The social determinants of health issues that are in play, patient navigation, psychosocial support that a patient really needs to effectively understand, manage, work with their team, and get best quality care as well. Quality improvement and quality in care has been, I think, a big lever that the healthcare system and medical societies have used. So how can we drive quality in care? So we're doing a lot of IME, for example, independent medical education, around making specialists aware of the disparities that are out there and the things that they can do in their direct care of patients and institutions as well to improve care. And the last piece is really adding our voice in our actions to dismantling structural racism and other kinds of structural determinants of health that really confer significant disadvantage to populations that harm their health as well. So that's the overall approach that we're taking at BMS. It's early days. We're going to have a lot of learning that we'll need to do, and a lot of changing, and we hope to learn from this community on how we can accelerate towards really being that inclusive and equity-driven pharmaceutical company.
Great. And Annette, I'm going to ask you to add on just a little bit, because I know BMS also has patient support services. Could you talk a little bit about that piece?
Sure. I mean, I'd love to elaborate on that. So, you know, at Bristol Myers Squibb, which is true for many pharmaceutical companies, we have very robust patient services where we work to maintain access for a patient, to help with copays. We go to organizations, and I know Holly, working with organizations like COA to make sure patients even get transportation to the doctor's office. You know, I will say one thing that my department does is really ensuring that we have resources, because a lot of social determinants of health and these questions, physicians, healthcare practitioners just don't really have the time to have the discussion, or uncomfortable about talking about it. So we have developed non-branded tools that we can share with healthcare professionals to just screen with basic questions. So I think of some of the patients that Holly may see, you know, they're dealing with cancer, but they may also be dealing with their electricity is going off. They can't pay for the food every day. So we have developed screeners to just have that conversation. And it may be very difficult face-to-face. So when you actually have a hard copy that you can give out, patient can maybe fill that out in the waiting room. Then when they go see their healthcare professional, they can look at it. There's no question where there's awkwardness, or there may decrease some of the awkwardness for that. But I think we all have to be open first to have that discussion, identify where the issue is, which is a key, especially when there's just minutes that you might be able to spend with the healthcare professional, and have that discussion. I think one, identify that, but also to the point of starting screening and asking these questions. And to Danielle's earlier point, we know that the patient that's engaged in taking care of their own health, having those open dialogues of their health and financial stability, all of that, you're going to have better outcomes. That has been proven in many studies.
Bring up a really great point. And Danielle, I think it was your organization that did a survey, but 64% of members said they felt unprepared to address patients' social needs. Can you just kind of elaborate on this whole concept and how AFP is recommending, you know, what are your thoughts in terms of how you support these physicians who really don't feel necessarily prepared to deal with some of these issues?
Yeah, so shortly after we conducted that survey, we launched in 2017 what we called the Everyone Project. And if you want more information, you can go to our website. It's www.aafp.org/everyone. And the purpose of the Everyone Project was to prepare our members with education, training, and practice tools that they actually needed to be able to address social determinants of health, both in the clinical space, but then also upstream in the community. Because for many of our members, this is essentially why they went into the practice of family medicine to begin with. And they saw us as their membership association as able to provide them with the support that they were looking for. So by developing this education and training, screening tools, referral resources, practice implementation guides, I feel now our members feel they have the tools and the skills and the education they need to actually intervene in an evidence-based way that's on behalf of their patients. And so in the period since then, we've actually been able to provide numerous hours of continuing medical education credits, about 130,000 hours of CME, which is almost 45,000 unique learners. And that's been on topics of health equity across social determinants of health, issues of birth equity, implicit bias. So not only should they now feel prepared, they should definitely feel empowered.
Holly, it seems like, and Danielle, I do want to let folks know, we have put that link in the chat box if people are interested in that Everyone Project. Really great program. So please visit that site and find out more about that. Really great resources there. Holly, so talk a little bit about Jasper Health, because Jasper Health is kind of a little bit of a wraparound to support some of these issues, a different type of tool.
Sure, Jen. So Jasper Health, you know, the vision and mission of Jasper is to be that solution that's available for all individuals and caregivers that are affected by cancer, no matter their age, gender, race, demographic location, or social economic status. We all know probably on this call that cancer remains as one of the leading causes of disease and death, and can be really challenging for individual patients and their family to navigate. Our goal here at Jasper is to reduce that overwhelming factor that, you know, by organizing their lives and needs and options in a way that really helps them improve survivorship and long-term health. Studies have shown that, you know, health inequalities are more prevalent in our aging population, and with no surprise, that is our growing population in cancer as well. There are so many ways that inequalities faced by these cancer patients can be addressed. However, some of the ways that Jasper can really support is helping our patients and the caregivers with resources and education, which seems like to be a theme among my panel as well, surrounding them with, better access to treatment and providing a personalized human touch approach to their needs with our care coaches. When a patient's diagnosed with cancer, we know that there's just so many factors that are not related to their disease or the clinical presentation, but that really impacts their care and survival. And those factors really are around their social needs, right? Financial hardship, food insecurity, housing insecurity, and transportation needs. Well, that's really where our care coach team, as I heard in some of the other panelists, having a team that can really, work with our nonprofit partnerships as well and provide that psychosocial support surrounding the patient and the caregiver throughout their cancer journey, because it really has been proven in a lot of studies that really taking this standard of care reduces distress and psychosocial morbidity and fosters better quality of life during and after treatment, and even eventually increase in survival for our cancer patients.
And now I'm going to bring, it's 1:23 and we haven't mentioned the word COVID yet. I think this is a record, but I want to ask all of you, and I want to get your input here. How has COVID really changed the conversation and the focus of health equity? I think we can just blanket statement, we know it's shined a light on it. But how has it kind of changed the work of your individual organizations as it addresses health equity? And it'd be great to kind of get a sense of that a little bit. Patricia, why don't we start with you?
Sure, thanks. So I think, broadly across our organization, just like across society, folks that maybe weren't quite aware of how health disparities manifest and then that there are driving root causes underneath them. It's not any longer, I think, if the patient would only do this, then they could achieve outcomes. I think it's really raised an understanding that it's structures, it's systems that are not responding to patient needs, and that is much more so contributing to the disparities that are out there. So I think just an awareness that this is real and that the causes of it lie in different places, but also the opportunity for the entire ecosystem, whatever lever we have, wherever space we sit in, to look at ourselves and say, how can we understand these disparities better? What are the actions that we can take on our own to help close those gaps? And of course, partnership is everything. I think we know this is a team sport in terms of health equity. So how can we collaborate with others and bring our strengths and assets together with others' strengths, including the expertise of communities and knowing their communities, knowing what strengths lie there to fight disease and to create positive change in communities, and really tapping into that as well. So I think that's the other thing, is that those of us who have been working in health equity and social justice space for a long time know that the community engagement is the first piece of it, and co-creation of solutions. But I think now there is broader understanding of that, and we can see how that is coming into work that teams across our company are already doing, really listening to what is the underserved patient's perspective? What are the diverse patient journey perspectives? How do we pull those in and then respond through the levers that we have and the tools that we have to engage more positively and to create change as well?
Great points. And my partner in crime, 1A, is over in the chat box here. I see getting a lot of discussion here. Tell us what you think about COVID and health equity as well, as we move on to this for a couple minutes as well. Danielle, how about with practitioners?
Yeah, I think for us, the combination of both the COVID pandemic and then the social justice movement, it forced us to reconcile that any of our efforts to address health equity are futile without also simultaneously addressing issues of racial equity. So for us, we definitely took the perspective that as we are developing strategies and objectives, having goals to ensure that we don't revert back to the status quo, before this period of time. And that means advocating for accessible healthcare access and delivery, the incorporation of telemedicine solutions, adopting those new innovations that can reduce administrative burden for our healthcare workforce, to give our physicians more time with their patients and less time doing paperwork, and incorporating those inclusive technologies that we know are going to have a better healthcare delivery system that is rooted in primary care.
Great point. Annette, you want to add on?
I've probably seen two major differences over the last few years, I would say, with our customers. I've seen new positions being popped up, both on a IDN hospital level, as well as payer level, on now C-suite, on health equity positions. So the people that we meet with, this is at the forefront, not only at, every level, but, at a higher up C-suite. This is a topic of conversation with everyone that's in the healthcare industry. So I think that's one is important because it's something that's obviously being highlighted by different parts of healthcare. And two, what we've seen, it's really changed how healthcare is being delivered. If you think about 2 years and getting access into seeing, hospitals or physician practices, we had to learn to pivot. There's a lot, I never thought I'd, talk to my physician over Zoom, but now it's not uncommon. So we're really having to take technology, and, that might be a challenge with some, in health equity. Not everyone has access to a computer or the internet, or maybe not even be able to read at a level or understand. So it's all of that, but I think COVID has expedited that, some in good ways when you have these different organizations that are putting it at the forefront as a mission statement and at C-suite level, but also realizing that, yes, we have to change how we're getting access to our healthcare.
One thing that I think we heard throughout COVID was that, there was a significant delay in terms of access to care for a lot of cancer patients. Are we starting to see that change a bit? Where are we at right now?
I do see it changing a bit. I think we still have some work to do, right? Especially for, certain populations that, have more challenges on accessing cancer care. But, one of those silver linings that we captured from COVID-19 pandemic was that many of the digital solutions that a lot of people were relying on during the pandemic would remain. So that would really make digital health equity, including digital access and literacy, even more important. And so it really opened the lens for us to care for these patients outside of a clinical setting.
I want to talk about that a little bit about some of the burdens of care that impact access. And one of the things we haven't really talked about is some of the financial burdens of care that have really a result of social determinants of health that impact access, and how do we help people pay for these things and address that. Annette, I know that's something BMS is working on. Maybe you could touch on that a little bit.
Yeah, I encourage everyone to really look into what pharmaceutical companies can do to help with offsetting costs. I think there are a lot of services that no one touches on, but few of them on the patient services. We have excellent patient services in terms, some of it depends on, policy, depending on what type of insurance you have, whether, you're less than 65 or above 65. Having said that, some of the things that Bristol Myers Squibb will do, I did touch on copay assistance, benefit investigations, help with understanding insurance. We have for all our products something that is very important for us. As I said, in market access where I sit, it's our goal as much as we can and allowed to is getting access to patients. But I really encourage everyone on this call to understand what can be offered, obviously variable depending on the patient and the product, but pharmaceutical companies, and specifically BMS, because I'm most familiar with that, has a lot of access to great patient services to decrease some of the burden with the cost, as well as decrease some of the other things that might not be related to the product at all. So I would say, I encourage everyone, call up. You can easily find the information on the website. You just need to Google the product, and then it's probably one of the first things that come up would be patient services and what can be found. So encourage everyone on this call, take advantage of that, because I would say it's still a fraction, and there's a lot more that you can tap into that's not being utilized.
Danielle, what do you guys do with AFP to kind of help clinicians make them aware of some of these resources to help patients with financial burdens that are impacting their care?
Yeah, I think the biggest resource that we've been able to provide our members with, particularly, we launched a tool called the Neighborhood Navigator back in 2018, which was a partnership within what is Aunt Bertha, but is now known as Fine Health, wherein on our co-branded platform, both physicians, anybody on the practice team, and patients themselves could go in and search by zip code and find those resources that might be financial relieving benefits, after hours care, housing, transportation, you name it. And then work in a coordinated fashion to ensure that those social support needs that might have been addressed in a social needs screening tool could then be addressed with some resource that was out in the community. And we have seen uptake and use of that very high, particularly during this COVID period, particularly as folks were sheltering in place or folks were trying to figure out housing and sources of food. And so I think that has been a tremendous resource that we continue to try and promote to not just our members, but for anybody to use Neighborhood Navigator as a resource that has been able to provide a lot of support, particularly during these difficult times.
That sounds great. Let's make sure we put that in the chat too. Neighborhood Navigator, and Aunt Bertha is a great organization. We've had. They have
been an excellent partner.
Yeah, really, really good partner for a lot of these activities. So one thing that I think Annette and Danielle both mentioned was digital health equity issues. And Holly, I hope maybe you can address this a little bit, because we do have all kinds of neat tools and things if you've got a phone and you've got a computer. But what do we do for the folks, where there's a gap there and we really don't have internet access, don't have the mobile phone?
So first, I want to say I love Aunt Bertha as a clinician. I used it all the time. It was definitely a great source. So that question really brings to mind a patient that reached out to Jasper. She was a stage 3 breast cancer patient who was homeless and living in her car at the time. She had a free phone provided to her and found Jasper through Facebook and decided to call for help. She had no insurance and was also an illegal drug user due to the extreme pain she was experiencing from cancer. She was seen to others as like a drug user, frequent flyer, and really, no one wanted to help her. However, at Jasper, we definitely wanted to help her and get in a better spot. And we were able to help provide her with get her signed up for Medicaid insurance, her government benefits, and community resources for housing and food to really help her get on her feet. And just to note, today, she is definitely on the right path and she's focusing on her journey and thriving. But I really bring up this story because these are the patients that need our services the most, right? And because we've recognized that here at Jasper, this is why our solution is available to all individuals affected by cancer. For those patients that don't have access to technology, it's been important for us to connect with our community support groups and nonprofit partnerships within our communities that our patients live. And then also we have found out that even the most diverse groups that may not have internet or minutes on their phone to talk, they still had access to text messages. And so that really became an access point that we were able to start communicating with them because texting really became a powerful way to reach patients with the right message at the right time. And it also can be done in different languages, right? So the message can be adapted to cultural and language attributes of the population. So really, we have really taken a step back and really identified for all the diverse populations that we really take care of, how do we connect with them? And each population may be different.
I love that story.
Thank you.
It's just a great example of how you can really make the solution work. It's great. So one thing, I mean, you guys have all talked about these really interesting collaborations that you have going on with Aunt Bertha or other organizations. And I'm sure that there are lots of folks on the call today that want to figure out, well, how do I do that in my community? Or, I didn't know BMS had that program, the copay program. So, one thing, again, that I think EHI and we hear about a lot are organizations that want to collaborate, they want to find partners, but they don't really know how to go about doing that. So, Patricia, maybe we can just start with you. I mean, what do you recommend to folks in terms of how to do that?
Well, I can just share how we've pursued some collaborations. And at BMS, through our corporate giving, which is our charitable giving, we're really looking to support scalable solutions and what has been shown to work. And we recently, just actually yesterday, announced nearly $8 million in grants to 24 nonprofits across the United States to develop, expand, and implement community health worker and patient navigator programs. So we know that both of these interventions really do make an incredible difference for patients who are experiencing difficulty in getting linked to care, getting access to high quality care as well. And these organizations are across the country. The chat, thank you for putting it in the chat. The list of those organizations are there. So those are groups that you can reach out to now who are participating either already with community health worker and patient navigator programs, or they are building them. So they will have that resource in your community as well. I've also used NowPow, which also CMMI with its social determinants of health program and accountable health communities. That was an incredible resource in seeing at the local level, zip code level, what are the resources that are there. And then something I just add, particularly hearing Holly's story of the cancer patient, I think trauma-informed care is also a dimension of this. And Dr. Jide Williams, who founded Hip Hop Public Health, he's a wonderful neurologist up at Columbia University. He said, part of our question to patients has to be not only, why are you here today? How can I help you? But what's happened to you? So that you really understand what is going on with patients and don't just look at a disease or a complication that they have, but really understand the context and the origins of that, and then can get proper help to that patient, like addiction services as an example, alongside the other kinds of supports that they may need as well.
I love that. What's happened to you? Good question to add on there. Danielle, why don't you jump on here as well? What do you recommend for folks who are trying to find partners and resources? And I'm sure you hear this a lot from the clinicians.
Yeah, so I think for anybody that's looking to partner, particularly with family medicine, we have 55 state chapters across the country and even in some of our US territories. So I would definitely recommend reaching out to one of them at the local level because they are doing some amazing work. They are partnering with organizations to deliver care and access and resources on the ground in partnership with community organizations. They do a lot of advocacy in their state on issues of significant importance. And we're happy to help you establish those relationships and identify folks that you can partner with in your own communities that have some of the same passions and missions as you all.
We actually have a question from someone who's asking, what role do you see for peer services integrated in this delivery system? Anybody want to comment there? Are any of you working with peer services?
We work with some peer services of so survivors that have had cancer before or they're currently in cancer. And so they really get paired with our patients and really help them, support them along the journey. We have learned that, learning from someone else's experience really does help them, throughout their journey, because they can really ask that person, what are the questions I should be asking my doctor? What are the things I should expect, when I'm starting treatment? So we have found, in regards to peer groups, that are individuals that are currently either cancer patients or in remission, supporting actual active cancer patients has really been beneficial.
That's a great question here. Is it ever possible to achieve health equity without addressing extreme income inequality and structural racism? Annette, you want to tackle that?
Yeah, I think they go hand in hand. You can't, everything is related. I would probably say even more than just that. But yes, I agree. There's inherent racism that is occurring that can help and that can, has to be addressed. And yeah, with financial, of course. I mean, it's, health and, health is very expensive in so many parts. And as I addressed earlier, if there's trade-offs that have to be, sometimes it's, taking care of your child or, making sure you have electricity on the house. That sometimes healthcare gets put in the back burner. So we have to address it holistically for the patient and not just one disease and one maybe medicine. We have to look at the whole patient.
We are taking your questions. If you have questions, we'd love you to put them in the Q&A box or the chat box, and we will get to them. Danielle, how about AFP? How do you guys address or do you kind of concerns about extreme income inequality and structural racism?
So I would say they definitely go hand in hand. And when you think about the way the systems have been designed in our country, whether it's healthcare access, education, housing, you name it, because a lot of those resources were scarce, you had to create a tiered system of the haves and the have-nots. And unfortunately for our history of our country, that was along racial boundaries. So it is like I said, for us, we cannot address health equity without also reconciling that we have racial inequities that are the foundation and the roots of many of our systems that are unequal. So we definitely have targeted in how we address that by how we conduct research, the evidence that we generate, how that gets into things like the practice guidelines to be able to establish more equitable systems of healthcare delivery.
Jennifer, yeah, so I just add, I think probably all of the institutions here see themselves as anchor institutions in their communities. So investing in our communities, in the businesses and the suppliers, so supplier diversity as being one way to drive equity and economic development. And Bristol Myers Squibb, as part of its D&I and health equity commitments, joined a number of companies and organizations that signed on to $1 billion in supplier diversity buying by 2025, and we're really steaming quickly to get there through our team. But that supplier diversity program isn't just about purchasing. It's also about working with those diverse suppliers to help strengthen their businesses so that they can grow. So there are partnerships, for example, with Tuck Business School up at Dartmouth for those suppliers. And a great story I heard recently was that team working with one supplier who just had a domestic business, actually expanding now into the international business with some of the mentoring and support that's been provided there. We're also looking at how we can bring health information to those diverse suppliers and to their communities as an aspect of that partnership too. So, our investing in the communities, there's different ways, the grants that we have and those kind of partnerships that we have, but also using our buying power and also other kinds of technical assistance to strengthen diverse owned businesses, to strengthen the health of them, their employees, and the communities as well that they serve and that they work in.
Holly, one thing that your story brought up is the homelessness. And we do have a question or a comment on kind of the increase in homelessness and how that's kind of impacted all of this. What are your thoughts on that?
We definitely have seen an increase due to all the things that are happening in our world today. But, you know, the great thing about, you know, the nonprofit partnerships is that they have grown and the resources are out there to really help our populations to improve, you know, housing insecurity and things like that. You know, it's not something that's going to go away, and it's definitely more prevalent in certain communities than others, and even in certain, you know, certain, I would say, populations, right? But it's our goal and our job to identify what are the resources that we can tap into to try to eliminate some of those challenges for those patients. But I definitely don't think that it's going to go away anytime soon, but we can definitely address it with a lot of the resources we have today.
Annette, did you want to add something? You looked like you were about to say something. No?
No, I was just reading just that question over there, which I think is a good one about what will be the leading change. And, you know, I would say all of the above. I think it's, you know, I do think over the last 2 years, this has become in the forefront, and I see, you know, different organizations. There are definitely going to be policy changes. If you just see what's been happening over the last year, we know something is going to happen to address, you know, healthcare and delivery. So, and I think it was Danielle that said this, or it might have been Holly. I agree. Look at, there are so many organizations, local organizations that already have so many resources. And to address Jen, your earlier question about who to contact, you know, I will say BMS has a whole team of field account executives that would be happy to help address, and I know I'll talk about some of the resources that I shared, but I would say reach out to all your partners, you know, including the pharmaceutical industry, to get some of this information. There's so much untapped resources that are just not being used that, you know, I do think it's going to take, you know, grassroots effort to the federal government to make these changes, but I think it's slowly happening and changing.
Yeah, and Annette's alluding to this great question in the chat box about what is going to be the main driving force behind improving health equity in the next decade. Is it going to be federal, you know, laws, policies, big tech, or community-based organizations, or something else? It'd be great to, Danielle, if you have any thoughts on that.
Yeah, I mean, I think it's going to take all of us across sectors. You know, it's individuals and it's organizations pulling the levers that they have access and influence over, from, you know, the highest levels to even the grassroots. And so I think it's going to be up to, you know, when we think about, we're talking really about healthcare, but when we talk about our banking industries, our education systems, our housing, all of those pieces are all of one part of the puzzle. And so we've got to just start looking at who are the people of influence, how can we get access to the resources we need, how can we change policies to actually build the systems that we know are going to create the best outcomes.
What about the importance of accountability? Nicole's brought up a great question as well here. You know, we measure, we report, there are clear disparities, and what happens when they persist, you know? Yeah. How do we keep people accountable?
And I can offer, I think accountability comes from clear goal setting that's time bound. You know, for the first time ever in the White House with Dr. Marcela Nunez-Smith, we have a person for the nation who is in charge of health equity. It started with COVID, but certainly spreading beyond that. And so I know Bristol Myers Squibb would love to be part of public-private partnerships to drive what are set as national health equity goals. What are the gaps? What do we want to close? What is the time we're shooting for? And how can we then put all of our resources, as Danielle said, all of our strengths on the table together to push quickly towards achieving those time-bound goals. And they really do have to be goals that matter to communities. It can't be all process goals if we instituted this tool or that tool, but really outcomes. And as Danielle said, the feeling is there that now I count, now the health system works for me, now my health and my well-being and that of my family are actually better. So I think we're at a special moment now in this being raised to that level for the country. But within our own institutions, I know we're looking at what would be our goals as, at a BMS level that we can push to in a time-bound way. And our diversity, inclusion, and health equity commitments, which are time-bound over 5 years, begin to do that for us.
Other thoughts on how we hold organizations accountable?
And I agree with what Patty said. You have to have like smart objectives. You have to make sure, you're measuring this. But I also think, people have to speak up. It's people talking about it. It's people complaining. And, if you think about just racial inequity over the last 2 years, there was so much grassroots and it brought a lot of attention. Health equity needs to be brought to the attention. There needs to be advocacies, groups, and more discussion of this. And, all of us, on this call, we're just a small portion. We're obviously very passionate about it, but we all need to bring this up and, hold each other accountable.
Mm-hmm.
Go ahead, Holly.
Jen, I was actually gonna comment on, what is going to be a driving force behind improving health equity. So I totally agree with Patricia that we need goals, that we can focus on, but we need goals that matter to a patient or caregiver too, right? Mm-hmm. And understanding that efficient cancer care benefits everyone, right? It means more equitable access to high quality care and better outcomes for patients. And really, I think one of the areas that's going to drive the improvement on health equity is data, understanding all of the data that we're getting in from our patients and caregivers, whether that's our PRO data, wearable devices, claims, EMR, and really understanding that data becomes the central to enabling the unprecedented advancement through cancer journey. Continuing to innovate with data brings tremendous value to individual patients because then we can start to personalize that patient-focused recommendations and journey. And we can also make sure that we are supporting them along the journey based on what they're actually encountering in their journey.
That's interesting what you're saying. It sparked, how do you make it impactful to the patient or the caregiver? And it goes to like maybe a carrot or a stick. If we had made it so your reimbursement, if we made it so your star ratings would make a difference, then there's going to just be more attention to this. So that's a way of getting to be more accountability.
Absolutely, if it goes into your star rating.
Yeah, I know.
We see a lot of changes.
Exactly.
Right. Someone, I can't remember who it was, Patricia, who was talking about trauma-informed care. We had a couple of questions about that. Who had brought, or was it Danielle? Who had brought that up? But it's a term I think people wanted clarified.
Yeah, so I brought that. I'm sure Danielle has perspectives on this, and Holly certainly as well, and Annette from her experience working with patients too. So this really comes from the adverse childhood events, the ACEs study that really showed, looking across all kinds of demographics, race, socioeconomic, that people who experience adverse childhood events had much worse health outcomes, a lot more illness throughout their lives. And again, like irrespective of coverage and socioeconomic status and so on. So this is really something that broadly impacts the population. And so that's from childhood. Of course, we have ongoing traumas that are happening. Certainly, COVID, this reckoning, the historical trauma, of course, structural racism in the United States is another example. So there are all these different dimensions of trauma that can really be addressed through trauma-informed care, and there are many aspects of that. But just for practitioners who don't have an awareness of this, just bringing it into the kind of care model, having awareness that these issues can be in play and underlying, driving, exacerbating the illnesses that patients are facing, and perhaps even their ability to manage them. But if they were addressed with the right resources and the right care and support, that the patient can hopefully do better on that. But it's it's much more broadly understood as something that should be part of quality care. And again, the specialty care community is much further ahead on this than, the primary care community is much more familiar with this, and there's been a lot of education. The specialty care, oncologists, cardiologists, immunologists, etc., I think also need to become more educated about this, and that this is definitely in play for many of the patients they're taking care of.
I know 1A's put a few things in the chat box there for folks to take away from that as well. Okay, so I'm going to have each of you tell us what's the one thing that people can do in their communities to ensure that health equity is in care delivery. And I'm going to give you 30 seconds to think about that. So think about your one nugget. And meanwhile, 1A, if we can just pull up the upcoming events before we get to our 4 nuggets of what are we going to call them? 4 takeaways that everybody needs to take home with them today. While they're thinking about that, I'm just going to give you a headline here of what's coming up. We've got 4 really great programs coming up that I want to make you aware of. A wonderful program next week looking at trackers, basically. And we'll be meeting with several different Google doctors who are going to talk about the evolution of Fitbit. And if you think about everything we can do now that has brought us past just counting the number of steps we take, will be a really interesting session. So join us for that on the 16th. On the 24th, we're talking about the great workforce burnout. Everybody's talking about this. And really incredible, great conversation. The 22nd of March, we're talking about the interoperability rule. Is that going to change healthcare integration? Hopefully. We will see, and we'll be doing more on EHR usability and optimization and more technical program on March 29th. So please join us for those programs. We'd love having you at our events and encourage you to come back. Okay, now we're coming back for our 4 nuggets. What are the takeaways? If there's one takeaway you'd like people to think about, what would that be, Patricia, in terms of driving health equity in care delivery?
Well, I just wanted to, say thanks to the chat, because the answers are mostly in the chat. So thanks to our incredible audience out there. Well, I will talk about the community of the biopharmaceutical companies. And I think for us, the most important thing is to get beyond thinking of our contribution to health equity as largely in the diversity and clinical trial space, and push into the commercialization and access space. And Annette's certainly one of the leaders in this area, and then knitting those 2 things together. So how can we leverage it as much learning and through the diversity and clinical trials experience, and then flow that into better access and commercialization efforts after approval.
Great. Okay, Danielle.
I would say the one takeaway is that you cannot address systemic issues with programmatic interventions. I remember the old school public health days when we were trying to tackle obesity in nonprofits with cooking classes and grocery store tours, right? But if you're not addressing the cost of food, the accessibility of food, the supply chain of food, you're not actually going to get to your downstream outcome, which is obesity.
Great point. Great point. Holly.
I couldn't agree more with Danielle. I think we need to first attack those social needs with the patients, such as, financial insecurity, housing insecurity, food insecurity, in order to really, impact the patient in regards to their clinical wealth, right? We go back to Maslow's hierarchy, right? If you don't start at the foundation and you don't start helping them build that foundation and eliminate those social, barriers, we're not going to get improved health outcomes. So really understanding that, we really have to start, eliminating those social needs first in order to improve health outcomes and improve overall access to care and value of healthcare for cancer patients.
Great, excellent. And Annette, you get the last word.
Okay, thank you. I would say healthcare equity, it's a team sport. You can see here we're all passionate and we have very different roles and responsibilities. I would say don't be afraid to ask. We need to address this head on. Make this as a topic of discussion. Start screening and having that conversation, because it's a lot more than just asking about, what symptoms you're having. It's about everything else surrounding the patient. So be bold and make this a topic of conversation.
Wonderful. Well, I couldn't have said it better. So welcome to, I'm so thrilled to have the wisdom of these 4 women today. Thank you so much for joining us and sharing your insights. And thank you to everybody out there for joining us. We'll hope you come back next week for another program. This has been a wonderful discussion, and we will be sending out all the resources and the recording so you can share with your friends and family. So thank you, and have a wonderful afternoon, everybody.
Thank you.
Thank you, Jen. Thank you, Anna. Good to be with you.